Thank you, Mary. Good morning, everyone. A little more enthusiasm, come on. Good morning, everyone. So our panel is patients and clinicians on the front line of telehealth. I think it's an exciting opportunity for this audience to hear directly from the people that matter most in the delivery of telehealth, and that's patients, but also from the people who are obviously key to that delivery, and that's the clinicians. We are fortunate today to have a great panel. The panelists are all associated with integrated delivery systems, though, which is a slice of life of the applicability of telemedicine, and so we'll try to draw that out. Our objectives this morning are numerous, but one of them is to give you those real-world examples of telehealth from the perspective of both patients and clinicians. We also want to hear, very importantly, from patients about what works in telehealth for them and why and what may not work. And then finally, we want to understand the amplified benefits of telehealth in integrated delivery systems, especially when they're connected by an integrated electronic medical record. To help me today in discussing these topics, a great panel. First, I'd like to recognize immediately to my left is Dr. Neil Evans from the Department of, got to get your bio out here. Dr. Neil Evans from the U.S. Department of Veterans Affairs, the Office of Connected Care for the Veterans Health Administration. He's board in both internal medicine and clinical informatics. Within VHA, Dr. Evans is an active clinician. He manages a panel of internal medicine patients in the primary care clinic right here in Washington, D.C. But importantly, the Office of Connected Care manages the VA's expansive telehealth program and the VA's patient portal, MyHealthVet, the VA mobile program, and VHA's Innovations Initiative. And Dr. Evans is key in all of those. He oversees the development and implementation of enterprise-wide veteran digital health strategies, transforming care delivery across the care continuum, and importantly, geography, and facilitating alignment of health information technologies within the VHA. Just as a way of a little précis on his academic background, he's trained as a chemical engineer. You're a Blue Hen, right? Isn't that a Blue Hen, University of Delaware? And attended medical school at Johns Hopkins, where he also did his medical residency. To his left is Dr. Dennis Strong. Dennis has the title of Director of Mobility Technology for the Mid-Atlantic region of Kaiser Permanente. He is an emergency medicine physician boarded, and he joined us in 2010. He earned his BA in molecular biology at UC Santa Cruz, and I think you guys are the banana slugs. Is that not correct? That is the mascot for UC Santa Cruz. Attended medical school at Michigan State and did his residency at William Beaumont in Detroit. He's also a proud U.S. Air Force veteran. And one important thing about him that I want you to remember for later on in this conversation is not only is he board certified in emergency medicine, I need the glasses for this, but he is licensed in Virginia, Washington, D.C., Maryland, Florida, West Virginia, Pennsylvania, North Carolina, and California. And that multiple state licensure issue is come to life in Dennis's own credentials because he heads our House Calls Urgent Care Telemedicine program, and hopefully we'll talk a little bit more about one of the barriers that's been alluded to this morning about state licensure requirements for telemedicine. Finally, to his left, we have Miss Brenda Trueheart, one of our esteemed Kaiser Permanente members, who will give you the skinny on being a patient in the system and using the telemedicine faculties and capabilities that we have, what works and what doesn't work. Dennis will introduce her more fully later. Now, just by way of a little bit of summary overview first about telemedicine, and we want to make sure we're all grounded in the basic modalities of telemedicine. Often it's thought of as video medicine, and personally, yeah, I think I understand that, but I want to make sure that people understand that telemedicine has other aspects, and we, at least in Kaiser Permanente, and I'm pretty sure in the VA, try to exploit all of those modalities. They each have their own unique niche, and you're going to see some of that today. First of all, there are pre-scheduled telephone appointments, real interactive evaluative appointments that occur by telephone. That's telehealth. There is remote monitoring, usually with an interactive or bidirectional information exchange component. That's telehealth. We would go so far as to say that secure texting between clinicians is a form of telehealth. And speaking of sort of efficiency factors that were alluded to this morning, we feel that inter-clinician secure texting is one of the most effective increasers of our physicians' efficiency, and is one of the most popular things that we've introduced in the world of telehealth in Kaiser Permanente. We also believe in secure email in a structured format with interactive interrogatories that too can supplant a face-to-face visit. Not all secure emails can do that, but some can. And then finally, there's video-based, or I would say imaging-based telemedicine. Usually we think of that as video, synchronous, interactive, but it's also been alluded to this morning. There is store and forward asynchronous telemedicine. Very, very important in fields like dermatology, where there is a dearth of specialists who want to practice medical dermatology. There's plenty that want to practice cosmetic dermatology, but real medical or surgical dermatology, there's fewer of those specialists, and something like asynchronous store and forward dermatology is very, very useful in expanding and maintaining and distributing access. With that kind of overview, mini précis of the modalities of telemedicine, I would like to turn it over, with just 1 minute to spare, to our first panelist, Dr. Neil Evans.